So colon cancer. All right, so this is where we're down to the bottom over here. We have anywhere in the colon, right? The ascending colon, transverse colon, descending colon, sigmoid colon, rectum. All these are colorectal cancer, right? So we have colon cancer over here. Okay, so again, same thing. We're going to know some general stuff about it, some symptoms, some causes, some symptoms, some treatment, what are the complications, and what can I do about it, right? What can I teach them? So, spoiler, you have to teach people to get surveilled for colon cancer, right? Colon cancer is very, very slow growing. To make one polyp, which is the cancerous piece, takes 10 years to make one polyp, right? Unless you have some genetic disorder, right? If you have familial adenomatous polyposis, you form 1,000 polyps, right? You're a polyp machine, right? So those patients need to have their whole bowel taken out by age 40. So because they're going to get colon cancer guaranteed. That's a genetic thing. And you would know that. He's like, mom had her colon out, dad had his colon out, right? So anyways, there's familial reasons, but also there are reasons you can just develop colon cancer, right? So we'll talk about inflammatory bowel disease. That's Crohn's and ulcerative colitis, right? If you've had those for more than 10 years, you're really high risk for having colon cancer. So those guys need to be recommended to get what procedure? A colonoscopy. So down there in the bottom middle, that's a polyp, and we go in the colonoscopy, we go in there and just yank out the polyp. Okay? So what else? So colon cancer is up there, third most common cancer and cancer death in the United States. What else on it? So diabetics are high risk, lifestyle changes, inactive, obese, smoking, alcohol, all those things. You can say smoking alcohol pretty much for every cancer. But what else? Red meat, more than 7 servings per week. That means every day you have red meat. Not good. All right, processed meats are not good. What other cancer had processed meats as a problem? Gastric cancer, right? So you want to kind of know which ones are the same, and you can then different. That's a good static question, right? Which one of these cancers have a risk of developing cancer when you have which one of the following, right? So you have processed meat ingestion, right? What else? We have a high-fat diet, low fruit and vegetable intake, high red meat intake. These have been associated with colon cancer. Okay, so polyp is just an overgrowth of tissue, and that can grow and grow and grow and mutate and start occluding the lumen of the colon. And the symptoms are very, very vague, just like gastric cancer and duodenal cancer. They'll have the iron deficiency anemia. They'll be losing blood slowly. They'll be feeling weak and fatigued. Very, very non-specific symptoms. So I think here we have the pathophys of colon cancer. So we've got, here's the top right are your alarm symptoms for GI cancers. So colon cancer is the same thing. We got unintended weight loss, right? We got some GI bleeding. We have a mass that's palpable. If they're thin enough, we can palpate a mass there. And there's some tests you can do to see if they have a slow bleed or not, right? Metastasis, it usually goes to the liver, but it can go anywhere. So we can do labs to make sure the liver's not involved. We can do the same thing as before. We can do CTs and PET scans. But usually the best thing is colonoscopy, because that's going to be, not for metastasis, but for management, is to get the colonoscopy routinely, right? And we'll talk about how routine it has to be. The symptoms can vary. So those are the alarm symptoms we're going to carry over from before, but it's insidious. And what does insidious mean? Scary movie, right? It means slow. It's a slow onset. How slow? About 10 years to grow a polyp, right? So usually we recommend getting a colonoscopy every 5 to 10 years, depending on the risk factors. Okay. What else? Changes stool shape. Might turn pencil shaped, right? So it's gonna, especially if it's it's going past a mass, it's going to get the shape of that mass, right? So it's pencil shaped mass is one, and I found this interesting. Where is it at?
Instead of a cuckoo clock, see, this is a poo-poo clock. And what we did see is we took them turds and we crammed them in between the number there, so that's 130, 230, 330. Now over here we make fecal people. And depending upon the shape of that middle turds right there, we can do them with big boobs or guts or butts or long legs or short legs, see, because there's no two turds that are ever alike. You ever seen a turd, the two turds alike? No. I get $5 a turd for these things, so I get jumping right up and down. I get excited when I see a turd.
So pencil shape is different. All right, so yeah, different sides of the colon can cause different symptoms, and you can palpate a mass. You have this slow bleed. You can have a what else? You can have unintended weight loss. The same things that are signs of most cancers, right? So I think this flow chart is the same thing. You can get a mechanical bowel obstruction. If it grows big enough, nothing can get through. It can ulcerate and it can cause perforation. It can cause a bleed. It can keep growing and growing and growing. All right, it's mass effect. Appetite can be poor. They get constipation. They get the unintended weight loss. They get hematochezia. If it's on the left side or right side, do you think? On the left side, it probably more cause hematochezia than the right side. The right side can cause cause a melanotic stool. And then iron deficiency anemia with slow loss of iron over time or blood over time. All right, so diagnostic tests. So colonoscopy is where it's at. That's where we can do to diagnose and screen it, and also we can remove what? We can remove those polyps, right? We can stage the cancer, the TNM staging. This is for every cancer has TNM staging. What's TNM stand for? Tumor node involvement, like lymph node involvement, and then M is metastasis. Which one of those gets radiation? Usually an earlier stage 1, 2, or 3. Sometimes they combine it. They got stage 4 chemo and radiation. Okay. What else? We can do, again, the CT, MRI, PET scans will look for metastasis. Labs can look for metastasis as well. If the liver enzymes are elevated, they might have liver involvement, right? Increased serum CEA. Which other cancer had increased serum CEA? Gastric cancer. So those are the two cancers that have elevated CEA. Does esophageal cancer have it? No. That sounds like a sad question. Anyways, what else? We've got treatment. You can fix it with a colonoscopy, right? So colonoscopy, you can just remove the polyp. Chemotherapy might be needed. And if you were looking, when we come back to chemo later, this is usually the regimen for most GI cancers, this FOLFOX, FOLFIRI. And the way they come up with these acronyms is kind of crazy, but they kind of just, they sometimes mix it up. They sometimes get creative with how they're combining all the medications. But usually with chemotherapy, it is all research-based and evidence-based on research on the best combination. So it doesn't make too much sense how they come up with this medication versus that medication. So that's the challenge with chemotherapy. All right, radiation, we talked about surgery. They got to resect the bowel. And if they do that, oftentimes they're going to need to have a colostomy afterwards. All right, so screening. So for screening for colon cancer, usually age 50, you got to get a screen. Otherwise, 45 if you're not white. All right, so white people, age 50. Not white people, age 45. Okay, so that's the higher risk, epidemiologically, prevalence-wise. You should have a colonoscopy younger, age 45. Even younger if you have like a genetic history, like mom or dad had it, or you have that familial polyposis. All right. So basically, colonoscopy is the gold standard. You can get a sigmoidoscopy, but why not just go all the way? If you're gonna get that, just do it. All right. And then you can get a what is it called? A video scope, like a capsule. Right. You still have to prep for it. You get a little video capsule. It's the worst VR experience you ever experience. And you can sign up on the Steam store. Anyways, you go up and you get you can watch someone's whole journey from mouth to anus. And you're looking for polyps the whole time. It's like a VR experience. You look back and forth. I'm kidding, it's not VR. But it will look. You'll take all kinds of pictures every few minutes, and the doctor can then assess if they see something suspicious. If they see something suspicious, you need a colonoscopy anyways, right? You got to have to go through a whole new round of prep again, and that's the worst experience ever to go through bowel prep. They can do a FIT test, not like a N95 FIT test, but a fecal immunoassay test where they're looking for the specific breakdown and biomarkers for cancer, for colon cancer. So they can do that, and they just at-home test where you just put it in a box, right? Every year, it doesn't stay there for a year, but you put it in every box, and then you just send it out, and they run a little sample on it to see if you have risk factor or have those. What am I trying to say? There's those little pieces of colon cancer. Okay. What else? Stool DNA test is something that's newer, but that works too. But again, if they see something, you need a colonoscopy anyways. Colonoscopy is the gold standard. Okay, and then up to the top right there, we have our symptoms of colon cancer. Right, they're quite non-specific. If they do see something early, that's actually to their benefit, because they usually are not going to feel these symptoms. Okay, they might have the pencil-shaped stool, they might have the GI bleed, they might have the fatigue, unextended weight loss, but the best thing to do is get a colonoscopy. At what age? 45 or 50. All right, so colonoscopy. So you need to have adequate bowel prep, right? It needs to look good for the GI doctor. You want to impress him, right? So here's excellent prep right here on the left there. So the excellent prep, they can see all the pieces of, not the piece of stool, but the pieces. So I didn't put it here, but sometimes a polyp is just nice and it looks like a little deal like that. But sometimes it can just be a little abrasion. Sometimes it can be an indentation. So having an adequate prep is what you need. Oh, it's right there. What am I doing? So it's right here. You want to be able to see those things. Those things can be hidden if you don't have adequate prep, right? So it needs to look like lemonade coming out, right? And that tells you that you have a adequate prep and they're ready to go for a colonoscopy. So Go Lightly is the typical solution we use. Was it 3 liters, 1 liter, 2 liters? I forget. But it's a huge deal that they have to hit overnight, all right? It's not called Go Light, it's Go Heavily. And it's polyethylene glycol, just like Miralax, right? And it's actually one chemical symbol away from ethylene glycol, which is antifreeze. So you can advertise this. You can drink this gallon of antifreeze overnight. Anyways, you have to swallow that to prep the bowel adequately for the colonoscopy. Okay. What else on that? Usually they'll hit up them with the mag citrate. Does mag citrate cause diarrhea or constipation? Diarrhea. All right. All right. What's this here?
Six o'clock already, I was just in the middle of a dream. I was stretching an esophagus with the wire-guided Savory. Well, I can't be late because my mentor is already annoyed. It took me 27 minutes to bandido my last hemorrhoid. It's just another endo Monday. Stick a camera up a bum day. Get past the valve to the C-cum day. Don't perf a diverticulum day. It's just another endo Monday. My mother wishes I had picked a more prestigious specialty. But saving lives through screening colonoscopy seems better to me. My father likes to look down on me cause I don't do surgery. Try endoscopic retrobrachial angiopancreatography. It's just another endo Monday. Spray some lidocaine to numb day. Biopsy funness and antrum day. Nystatin for candida scum day. It's just another endo Monday. Stick a camera up a bum day. Get past the valve to the C-cum day. Don't look for diverticulum day. It's just another endo Monday.
All right, so take a break. Come back at 50.
Recording in progress.
This is a colostomy, which is created when the large bowel is surgically removed from the body. Now, this may happen due to inflammation like Crohn's disease or ulcerative colitis, or due to colon cancer. Now, the stool still needs somewhere to go, so a connection is made between the bowel and the abdominal wall to allow all that waste material to collect. Big shout out to Mesha for normalizing colostomy bags.
All right, so colostomies. So we talked about what some examples you said. You said inflammatory bowel diseases. We got colon cancer, and what else did we just talk about? You got diverticulitis, right? That can perforate. Sometimes even a bleed from the diverticulosis can be significant enough that we can't handle it and we have to resect it, right? So colostomies, these are a resolution to a bleed or to when there's infection usually. Like when you have a huge widespread infection in the belly, you can't just anastomose the two ends together, otherwise it's not going to take, right, with all that infection brewing, right? So colostomies. So we have incontinent types, these are usually like the ones that we're going to start with, like emergently usually. Colostomy and ileostomies, it's just a real quick way to manage someone's, to divert away from the infection or to temporarily fix the patient, right? And they are incontinent, it just flows out, right? So you have colostomy and ileostomy, and they flow out at different rates. Which one is more liquid? Ileostomy or colostomy? Ileostomy, right? Where's liquid absorbed? Where's water absorbed? In the large intestine is where all your water gets absorbed, right? So what else? So there's advanced versions where they might have like a permanent reason for colostomy. So there's different where they can make them continent. They make little pouches basically, where then they can just squeeze it out, right? They have they're called cock pouches, and what else? They have W pouches, M pouches. We have there's even urostomies, patients that need to diversion from their ureter, from their bladder over to the abdominal wall, and it goes into a little pouch, like an intestinal pouch, and then they can then catheterize themselves to take out the urine. Okay, so colectomy, mucosal proctectomy, ileal pouch is called a IPA. That's just another way to, it's another continent pouch that's available where they get really creative and with different pouches they can make. Okay, so what else? So we want to make sure, so these are examples of why we need an ileostomy versus colostomy, right? So Crohn's disease we'll be talking about today. We talk about, is diverticulitis in here? There it is, right? You get diverticulitis, colon cancer, and so forth. So we created the colon cancer, but now, we created the colostomy, but we got to make sure that it is working and making sure that the assessment findings are good. So the bottom right there, is that a good assessment finding? No, it should not be dusky or black or necrotic. That is never good, right? So it should not be like this. That is incorrect, right? And here we got a necrotic tip, just the tip. Is that okay? No. So, all right, so what about if it's like hanging out, showing off? No, I mean, that's actually okay. You can, it's okay to be like that. It's not a big deal, right? What is a big deal? What if it's herniating? It could strangulate the bowel around it, right? It needs resolution. So what color should a stoma be? It should be beefy red and moist, right? So beefy red and moist. All right, so here's a nice, beautiful ileostomy, colostomy. All right, so beefy red. If it's dusky and cyanotic, that's not good. Is it sterile technique or asterile technique? Or sorry, aseptic technique? It's aseptic, right? So it's just like putting sterile gloves on to wipe someone's butt. You're not going to do that, right? So what else? We got stoma output should be less than 1,000 per day. Like you're not going to get 1,000 out of a colostomy, but you might get out of an ileostomy. So we got to slow that down. We can give medications to slow it down if we need to. But if it's too much output, they're high risk for dehydration, just like diarrhea, right? Ensure the dressing is adherent, not too tight, otherwise it can cinch off the stoma. But if it is if it's not applied directly, the stool can get underneath the dressing and start causing some moisture-associated dermatitis, yeast, psoriasis symptoms. So all these things need to be assessed on stoma change or stoma dressing change to make sure that there isn't redness. Maybe there's creams we can put. There's adherent powders. We can make sure that it's adhering good. All right. So these are the things we do nursing-wise to make sure that it is functional, for one, but also two, not getting the dermatitis associated with it.